I am so grateful for our friends at Blue Microphones. Not only have they completely changed what our show sounds like, they've given me headphones so I can monitor things better. This is the mic for millions of creative people, and now I know why. I'm so grateful for them completely changing the quality of our audio. You'll find Blue mics like Yeti and the Mouse, which we're using here, both in pro studios and home studios, literally all over the world. Their popular Yeti caster is a Blue Yeti microphone plus a boom arm system that's behind many of your favorite podcasts. I run into them all the time, and now I know why. If you've ever thought about creating your own podcast or YouTube channel, Blue can make you sound and look great. Just visit bluemic.com and click Get Started, and you can start telling your story.
Hey everyone, it's a dose of Dr. Drew.
It is indeed, and our special guest, Dr. Amy Barnhorst. Dr. Barnhorst is the Vice Chair for Community Mental Health at the UC Davis Department of Psychiatry, Director of the BulletPoints Project, something we'll get into, state-funded effort to develop firearm violence prevention curriculum for healthcare providers. She is dealing with, amongst other things, serious mental illness in the emergency department. We're no longer able to say ER, are we? We have to say ED, emergency department, county jail, crisis unit, and a 50-bed inpatient psychiatric hospital. Dr. Barnhorst, thank you for joining us.
Thanks so much for having me, Drew.
So let me just start with COVID, because that's always sort of what's on people's mind.
Yeah.
How and I'm guessing you're seeing the acute side of psychiatry predominantly, right? The
Yes.
Through the ER, ED, whatever, through the ER into acute inpatient setting. Is that mostly locked? Is that a locked facility, or is that?
Yeah, it's a locked facility. Almost everybody I see is on either an involuntary hold or a conservatorship.
Okay. So what have you seen, or what are you seeing now that you think is some of the collateral damage of COVID?
You know, it's complicated because part of the collateral damage is people not being able to move through the system to the appropriate level of care because, for example, psychiatric hospitals will have an outbreak of COVID and not be able to accept new patients in the ED.
Yeah.
So patients are sitting in the ED, and the ED is getting overwhelmed because they have COVID patients coming in and psych patients waiting for beds. People in the higher level of service providers that we have here are not able to have their case managers come out because they're short-staffed, because someone in somebody's family got COVID and they're not able to do in-person home visits, or all of their appointments are over telemedicine, but they don't have internet. And so COVID has really thrown a wrench in so many small and big ways in terms of people getting care at the level they need. But then on the inflow side, it's kind of pushed, I think of mental health on a spectrum. There's people doing great, there's people with mental illness, and then there's folks kind of in the middle that might struggle, but do mostly okay in the best of times. But you throw in a bunch of life stressors like, loss of employment, relationship stress, schools being shut down, economic stress, fear about the virus. And those people, and then even more logistical things like not being able to get to their doctor's appointment or being afraid to go to the pharmacy. Then you're going to push more people into the mental illness part of the spectrum. And so there's more people who are having problems managing their day-to-day symptoms that are doing worse than they were before, maybe having suicidal thoughts. And so we're seeing more inflow, less outflow, and a lot of people needing services.
Right. So whenever I talk to my psychiatric colleagues, they essentially just go anxiety, depression, anxiety, depression, anxiety, depression. It's just so much of it. And particularly the child and adolescent psychiatrists. Those that seem just completely it's just out of control. So here we are. A lot of, to my humble estimation, some of it is, fear and anxiety. Some of it is isolation. Some of it is boredom. And then what I expected and what I've seen is the uptick in substance use, alcohol. I thought for sure alcohol and overdoses. That's what we'll see, and that's what I've been seeing. You've seen the same thing, yeah.
Although it's interesting because it doesn't look with prelim data out, it doesn't look like the suicide rate went up the way a lot of people
I saw that too. What do you make of that?
Well, it's hard to say. The suicide rate rose from 99 to 2018 by over 30%. It just was on this steady climb. And then for whatever reason, 2019, it dropped a little bit. And then 2020, everybody was saying, oh yeah, this is going to be an awful year for suicides. And there was a big bump in people having suicidal thoughts, something like 25% of young adults said they had seriously considered suicide over the summer, which is huge and is way more than, we saw in prior survey data from previous years. But yeah, it doesn't look like that happened. And again, the data is not finalized. It takes a while to really know that all the deaths are in and accounted for. It may be that suicides were on the decline and COVID could have even slowed that decline, but it's hard to know from a snapshot in time. We need to look at really long trends to be able to say what's happening.
So we're seeing it, we're just not sure what it is. It's surprising because in the face of all the anxiety, depression, and substance use, you would expect suicide to be part of that.
Yeah.
Yeah.
And people have all kinds of, some people are saying, oh, it's all the work we put into suicide prevention, which may be helping. Some people are saying there's this phenomenon during a national crisis where people really bond together and feel a sense of community and kind of purpose and contribution. Who knows? It's really all speculation.
Yeah, but this was sort of the opposite, wasn't it? I mean, because we were also isolated and disconnected from community, although maybe it's hard to know. Or maybe we got closer to our families, or maybe being under the watchful eye of people that are in your life all the time, no opportunity to act out suicidally.
Right. I mean, it's all speculation at this point, but we could speculate.
We'll speculate. Yeah, that's kind of what I was thinking. I thought, because I couldn't make sense of it, I thought, oh, there's always somebody else locked in there with you for the most part, especially if you're an adolescent.
It's true. Although, we've seen big spikes in firearm sales, and that is strongly associated with suicide because firearms are the most lethal and common method of completed suicides. And so, again, we expected it from that, but that hasn't been borne out.
Is there a sex sort of ratio involved in the numbers of people presenting with symptoms? Well, what made me think of this is just before 2019, when things were sort of peaking, one of the reasons it was peaking is we were seeing a lot more violent deaths at the hands of young ladies, young women. And I'm wondering, is there any sort of sex differential now going on in terms of the symptomatology?
I can't say for sure. I don't know what the data is. And I would say from my clinical experience, which is just anecdotal, I can't really say one way or the other that it's men more than women or women more than men.
Yeah.
I think there's data to support that it's definitely folks who are at the lower end of the socioeconomic spectrum who maybe have less job stability, who weren't able to, work from home, help their kids through online school. They don't have a laptop for each high school student or each elementary school student. They have a lot more stress, a lot more COVID exposure. So, people of color, people working in service industry jobs, those kinds of folks are being hit a lot harder by the mental health problems.
Yeah, I because you're not child and adolescent, right? You're adult psychiatrists.
No.
Yeah, I've been communicating with a lot of child and adolescent people, and one of the really serious things that has been happening is all the access through the electronic media instruments that kids have been provided have resulted in massive increase in kids finding, fentanyl online, porn online, abuse, being victimized online. That stuff has gone through the roof.
Yeah.
So, ugh.
And I know as being a parent of teenagers, taking away their electronics at a time when that is their only connection to the outside world, to their friends, to school, you just can't do it the way you could do it 2 years ago.
Isn't that interesting? I had not thought about that piece. Very interesting. Are there things that you're concerned about now in terms of, or what do you think about when when you're in quieter moments about how we get things sort of back on track? Do we just sort of keep dealing with the acute stuff that's coming our way, or is there something more we could be doing on a larger stage? I'm not asking a good question, but I think you know what I'm getting at.
Like, what do we do with the mental health problems we now have, and how do we go forward from here? No, it's a good question, and I'll be an optimist, I guess, and answer it by saying one silver lining of this pandemic is that everyone's talking about mental health now. When I was growing up and I was a teenager, if I had a friend who was taking antidepressants or who had been hospitalized for a suicide attempt, I never heard about it.
Right.
And everyone now talks about it. Celebrities are coming out about their experiences. Kids are talking about their struggles. People are going to therapy and comparing their therapists. There's all kinds of articles about the mental health effects of COVID. So it is very much on the table. And I think that it's helped us see, that this was always a big problem, but now it's a bigger problem. the system we have built to address mental health and mental illness in our country is terrible and completely failing, and really needs an influx of resources and an overhaul.
All right, so I'm 1,000% with you. Well, other than more psychiatrists, what else do we need? Because we need more psychiatrists, especially in California.
Need more.
Especially in California.
Yeah. I think the majority of psychiatrists are over 55 years old practicing in the US. So the retirement bolus is kind of moving towards not even practicing anymore.
And everyone has moved out of the inpatient setting. I mean, you're one of the rare, all those years I spent working on inpatient psychiatry, all those, I'd say 70% of those folks moved out of it. It just wasn't the insurance, you know what I'm talking about, the insurance nonsense, which would hit probably a nadir in the 2010 to 15 era, just pushed everybody out. You couldn't take care of people.
Well, this is the good news about working for people who are uninsured or, have county insurance, is that you don't have to worry about that stuff because nobody pays anyway.
Yeah, but the hospital, if there's not
the hospital pays, right?
Beating on you, the hospital's beating on you.
That's true. That's true. But yeah, I mean, I think it takes a special kind of person to be an inpatient psychiatrist. And I will, maybe I'll change my mind, but I don't know that I'll ever do outpatient visits or therapy. It's not for me.
It's the most interesting work. I mean, it's just really where you.
Yes.
And as I was telling Dr. Barnhorst before the mics heated up, that when I first arrived at the psychiatric hospital, it was a museum of the history of psychiatry from about 1940 forward. And I was dealing with medically all the people that had had the psychosurgeries, the cingulotomies and the lobotomies, and a freaking disaster. Mm-hmm. Most of them were drug addicts or borderline personality, troublesome people, and therefore they cut off that frontal lobe. They're not troublesome anymore.
Oh man.
So whenever whenever people talk about the excesses and the history of psychiatry, you got a point.
You got it, yeah.
You got a point, but it's not that anymore, please. So I saw that. People that had dialysis shunts because they were going to dialyze away the toxins that cause schizophrenia. Yeah. I saw insulin shock therapy, para-influenza therapy, lots of electric shock therapy of various stripes over the years.
Yeah.
And I remember it was like just a big hospital full of very, like sort of one flew over the cuckoo's nest.
No. It was the aftermath of that. We had a lovely place. I mean, the people were extremely well cared for.
The ones that had been there forever.
The ones that had been there forever. But that's the one I want to get at. We had so I got to see all aspects. I got to see an inpatient addiction unit, a residential addiction unit, an outpatient addiction unit, an IOP addiction unit, IOP psych, inpatient psych, depression, personality disorders, med psych, all the med psych variations on the theme. But what I saw a lot of also was long-term care for psychiatric patients. Okay. And they did beautifully, and they would not have survived outside of these custodial environments.
Right.
And it's not like they were unhappy. They were very happy. They went on passes, and they had care, and they got their meds, and everybody was fine. We must have, in California alone, reasonably 20,000 people that need care like that aren't getting it, would you say?
I don't know, but it is a lot. And I see those people too. And, the average length of stay in a lot of acute psychiatric hospitals is on the order of days to weeks. Yeah. And I've seen people who get better, like remarkably better, 6-9 months after they've been admitted on meds. I mean, it takes a long time.
So to that point, we need not just those custodial units that people seem allergic to these days, but more, we need a continuum of care.
Oh, yes.
From acute to inpatient to outpatient to assisted outpatient. And we have no continuum. And $12 billion in the government's plan, I see no plan for a continuum in psychiatric care, no plan to bring more psychiatrists in, just more wraparound services, which I have no idea what that is. It should be full spectrum psychiatric services.
And a tiny house.
And that is something that I'm constantly beating the drum about, is that they're the people who say all we need is more inpatient beds because we have all these people on holds in the emergency room. They're waiting for a bed. We just need to build more beds. It's kind of like saying we'll solve the homelessness crisis by building more houses.
Yeah.
Well, both of these things are a lot more complex than just that.
Yes. Is anybody listening to you? Just that point? Is anybody listening to just that point? Because that sort of says it all, right? This is like, no, you guys, this isn't going to solve it because it's more complicated. Right.
Well, no one wants to hear that it's more complicated. Everyone wants a simple fix.
Yeah.
But you're absolutely right that there are people in in what's supposed to be an acute psychiatric hospital. There's some people who need to be there for 9 months to a year to get better, actually.
Mm-hmm. Commonly.
There's some people
commonly. That's not an uncommon thing.
Commonly.
And they will get better.
Yes,
that's the thing people need to understand. Yeah.
And unfortunately, as we know from experience, when they leave the hospital, they oftentimes, if not every time, they get worse because something happens, they stop their meds, they don't have a stable living situation. There's so many reasons. And so then they go through whatever it takes and they come back into the hospital and we do it again. And if there were a way to get those people into, like you said, this care continuum at a much higher level than just saying like, best of luck out there, where somebody was coming to their house every day, where they had supported housing, where there was a case manager, where they were on a long-acting injectable antipsychotic, they could do really well, but they need so much supervision. And the problem is, as soon as you start talking about that high of a level of supervision, or even a semi-locked facility where people can live, but like you said, go out on passes, what people hear is like, we're taking away people's civil rights and their freedoms. We're locking them away. This is a return to the asylum days where
those people need to shut up. That's insane because they need to shut up. That's insane. That's not what we're talking about. Shut up. Yeah. So now, why don't people understand that mental illnesses rob people of their civil liberties? Anosognosia, denial robs them. Lack of insight, distorted thinking robs people of their civil liberties. Where are the people defending that?
I think part of the problem with mental illness is that for so long as a society, when we have somebody with a serious mental illness, we just kind of hide them away and nobody sees them. I knew people growing up who had diabetes or a seizure disorder, had a heart attack or a stroke. I knew one guy with schizophrenia, and as soon as he had his break, I never really saw him.
Yeah.
Because it's not something you talk about.
Well, you're making a point that people need contact with people, real contact, not just driving by them in their tents on the street. They need contact with them, which is how we know that is the means of reducing stigma and fear. But I've come up with an interesting little theory. Have you ever heard of the uncanny valley?
Yes.
I think the uncanny valley with robots is some sort of evolutionary mechanism that makes us push away from people that look human but don't act human.
Right. They're just different enough.
They're just enough that they look like they should be human, but there's something weird going on. I got to push away. And there's something from an evolutionary people talk about it in great detail with robots, but that thing is operating with mental illness. I just know it. And we should be studying what that is and how to combat it. Because I think that's at the core of the, it's not even stigmatizing, it's just the pulling away, the pushing back from.
And that pulling away is so dangerous because again, people don't understand it. And I know as a psychiatrist, I deal with a lot of, we're like the least respected, but the most needed people in the health system. Like everyone kind of cracks jokes behind our back, but we sure get a lot of consults.
Well, I think that's changing.
That is changing. Yeah. It is changing. We're not quite the black sheep we were in like House of God days, but
so my generation is House of God days.
Yeah,
and that is absolutely true. And again, I spent practically lived in a psychiatric hospital for 20 years, not as a patient, as a staff member, and I saw it. And I will tell you what. And I was advising a young medical student the other day who really wanted to go in psychiatry. He liked the sort of character of the individuals in psychiatry, which is a nice. I thought that was a great. He liked the people in the business, which I thought was nice. But I told him, and here's the one thing: this is how you end up with the house. How you ended up with the House of God stuff. I told him, I said, don't forget your medicine. Don't forget you're a doctor. Pay really close attention during your rotating internship and take all of that forward with you. You're super smart. Don't let go of that. And I think the psychoanalytic heritage, which I didn't realize had such a grip on American psychiatry. I ran into those people in the 80s. I didn't understand that that was all of psychiatry at the time. And
Right.
they
Oh, yeah.
literally
For
they
a while.
dropped being a doctor. They literally just let it go. It wasn't important. And
Yeah.
I think that's how that stigma against psychiatry happened. And I think that's why it's shifting back, because most psychiatrists don't, they remember their medicine.
We try to. But, that's one of the reasons I like to work inpatient is I get to do more, medicine stuff there with medications and things like that.
Yeah.
But yeah, I think that is, part of it. And that's why I'm constantly explaining to people like, no, I'm actually a medical doctor.
Yeah. Yeah. They don't even understand that. You have to say physician.
Right. Exactly.
Because they don't even know what doctor means anymore. It's just
right.
Right.
But
in the 80s and 90s, I spent a lot of my time running around dealing with the medical side effects of psychotropic medications. And again, because the psychiatrists at the time had just came off their psychoanalytic high and were turning towards the biological, they were in sort of denial of all the
this stuff is magic.
So much stuff was happening medically. I was sort of horrified for a few years. Like, guys, calm down. This stuff can, every time you add another medicine, it becomes increasingly dangerous.
Right.
And so I'd be doing this consult. Why is the patient's legs swollen? Why are they hyponatremic? Like, guess what? It's like, that's going to happen from your meds.
Yeah.
So anyway, let's go back to what we can do. So we need continuum of care. We need environments for those continuums. So build more beds is still part of the picture, is it not?
It's still part of the picture. We need more acute beds. We need more long-term beds. We need more sort of supported housing, not really your own place, but kind of feel like your own place, but somebody's coming in and taking care of you kind of beds.
So wouldn't it be advantageous for that all to be a single campus?
That is the dream.
Okay, so yes. The answer is yes.
So yes.
If it's a dream, I'm imagining it's a good dream.
In an ideal world.
You didn't say that's the nightmare. You said that's the dream.
No, it is the dream.
So that to me is sort of you ever heard of the Trieste model?
Yes.
To me, that's that, right? Am I getting the Trieste model right?
Yeah. I read about the Trieste model and I think, why can we not do this here?
Yeah.
Why have we not done this here?
Correct.
I don't know that the demographics and the socioeconomics of Trieste folks are comparable to ours. And one of the biggest things is, particularly in California, is meth use.
Okay, so slow down. So you just packed a lot into a statement. So you're saying our group, the people that are going to need these services are lower functioning, we call it? Is that what you're saying?
It may be that they're lower functioning. It may be that their problems are different because, one of the other big contributors, I think, to, and I'm not going to say necessarily mental illness, but partially to mental illness, partially to poor mental health in the US, is lack of structural and social supports. And I just had an article
slow down. Destroyed families?
Destroyed. Yeah. I mean, if you don't, your family can be whatever.
Yeah.
As long as it's good and solid.
And structured. Yeah.
Lack of family support.
Yeah.
Crappy schools. Violence in your neighborhood.
Okay.
No educational opportunities.
So you read a paper. Tell me about that paper.
Well, I wrote a paper. It was in Slate, and it was called it was about how to fix people's mental health by fixing socioeconomic things like the stimulus checks that we're sending out, like having more housing for people and more protections against eviction, having better treatment for substance use disorders, that a lot of mental health rests on not psychiatric treatments, but on other things you can do to people's social environments that will really improve their mental health.
So, okay. So what I hear is, family, community, education, right? Really,
economics, jobs, and money.
Yeah, well, but jobs and money, I hear that too, but I would say that's sort of secondary, really. I mean, it's important, but secondarily important. I mean, it's family, community, and education, and nobody talks about that. They talk about jobs and money. I hear that, but I think that's missing a step, an important step.
Right.
Family, community, education. And in the meantime, we've kept kids out of school, by the way, which is not going to help an at-risk group.
Right.
Yeah.
Well, and going back to the Trieste model, so I don't know, it seems possible to me that the folks who were there grew up in a society that had all of the other stuff in order, didn't have a lot of meth, didn't have an opiate problem.
Yeah.
And so the people in there are like people with serious schizophrenia, but no substance use disorder. People with bipolar disorder, but didn't have terrible abusive parents when they were kids.
Family in Italy is intact.
So it's kind of a different ballgame.
And so is community, and communities are intact too there for the most part.
Yeah, and people have the supports that they need in some places. I don't think we do a great job.
So that's very interesting. So so now let's get back to the substance thing. So that's one of the things that drives me insane about about homelessness is I ran a drug treatment center for 25 years or 20 years, I guess it was, and these are my patients. That's what I'm seeing out there is opioid meth. Yeah. that's everywhere, and nobody's dealing with it, and nobody seems to understand that it requires a certain skill set to even be able to identify it in these people. Right. So when you say there's no substance use here, so you had a high school kid with a clipboard, and that you expect people to report their opiate and heroin use when they come up and say, do you do heroin? Do you do meth? It's like, of course not. Of course not. Of course not. I see it everywhere, and they're treatable disorders. But and particularly opiate use disorder. That's particularly
opioids. Yeah, I mean meth maybe less so.
Well, but you're seeing meth through a certain lens, which is the emergency department. Yeah. And I know how to deal with meth. You've got to put people in a place for 2 weeks and let them clear. You have to do that. They will not clear without that. And so if we're not putting people somewhere where they are required to stop using meth, they will stay psychotic or get increasingly psychotic, and they will eventually become violent, period. Right. That is what happens with meth. Why aren't we having these conversations? And let me ask this. Where has the American Psychiatric Association been? I'm so mystified that the APA has never stepped up and go, we got some ideas for the homeless. There's more psychiatrists, nothing, empty. They're silent.
Well, and I feel like the whole substance use mental illness thing is weirdly siloed, and even a lot of the regulations around billing within an inpatient psych hospital, that you can't do it for substance use disorders in certain situations. It's like people treat those like they're completely separate things, like the kidney and the left leg. No. They're not separate. They really go hand in hand. And so many of my patients I see sorry about that.
All right.
Either became
Susan, her computer rings her phone too.
All the time.
That's Susan.
I don't know how to turn it off.
She doesn't know either.
Either they became chronically psychotic because they did so much meth, or they were homeless and on the street and they started using meth because they were tired of getting,
Here's the thing. Here's the thing I get angry about, which is, humbly, here's the strikes back. I don't give two shits about which started first. It doesn't matter in terms of treatment. It doesn't mean shit. Exactly. It has a certain treatment once you get there, and the treatment needs to get done, or this person will die.
Right.
Period. Let's not have conversations about how they got there. Let the sociologist answer that. First, we got people's lives at hand here, and there are tens of thousands of them. Maybe tens and tens and tens of thousands of them. Yeah. And it's so hard to sit and watch them die. In LA County, we lose 5 a day. These are treatable conditions. And here's the thing that's insane. On all of the committees supervising the resources for homelessness, not one physician. Not one.
Wow.
If you had a ward in the hospital, let's say you had a wing of the hospital where people were dying at the rate of 5 a day, and there was no physician oversight, wouldn't you think somebody would go, let's get a doctor involved. People are dying 5 a day of these conditions. It's insane. It's insane.
Well, and I think part of it too is that, like with mental illness, there's some anosognosia that goes along with substance use where people don't recognize the problem. And
and all psychotic illness, let's be fair.
And
psychotic illness. Yeah.
She says it better than you do.
Anosognosia. What did she say?
She says it beautifully.
Say it again.
That's a lot of pressure. Anosognosia?
Anosognosia.
Yeah, it just sounded so pretty.
Kind of sounds like ambrosia, but
it just sounds better when it comes out of a female voice. Sounds kind of harsh when a man says it. But I've been chanting about anosognosia for about 2 years now, and I'm being told I'm cruel.
Mm-hmm. But it is the reality of mental illness, and it's part of the problem. Part of the problem is that people don't know what real mental illness looks like and how destructive it can be.
And because when people walk up to them and they seem sympathetic and kind and want to talk about why they're homeless, they miss the mental illness completely.
Yeah.
Completely.
Yeah. Or the people who have mental illness aren't the ones walking up and talking to the kid with the clipboard.
That's true.
My patients are not out there actively participating in the homeless programs.
Yeah.
And then the other part of it is that people don't recognize that this is not the worse the condition gets, the less likely the person is to seek help.
Right.
And then what do you do? And there is an important balance between people's civil liberties and, forcing people into care. You can't just say like, oh, well, I don't, and psychiatry overstepped that for many years.
Of course. Again, I lived it. But why don't we talk in terms of motivating people into care? So I know how to motivate drug addicts. It's not that hard. They really will go where you tell them to go.
Yeah.
They just will. And
as long as you have a place to send them. Exactly. I mean, that's what we struggle with.
Exactly. It's 100% true. But you have to go, you can't stay here, come here. And they'll go. They will go.
Yes.
I mean, we did that all the time. The time. Because what people don't understand, when people came to drug treatment, they come because their family or the courts or somebody goes, sorry, you're coming here. And they just go. They come to treatment. And guess what? We could do really well. We could do amazing things with them. Amazing, amazing, amazing. And many of my patients, thrive and thrive and thrive because somebody motivated them into treatment.
Right. And they had a place, that's what happens is our folks, we see them and they're in that moment of crisis. Like they're in a bad spot. They've lost their housing. They lost their relationship. Mm-hmm. They feel like crap. And we say like, well, hey, we can get you into treatment like in a week and a half.
No.
Good luck with that follow-up. They need to go then and there. And that just, it's not always available.
No, that's the rare patient that will hang out for that. That's unusual. And some do. There's such a thing, but that's somebody who, they're usually, I'll tell you who that population usually is. It's usually somebody trying to avoid jail or they're trying to avoid something. They have got they have a sword of Damocles hanging over them and they're trying to avoid it and they'll go into treatment for that, which is great. I have no problem with that. But we have none of that now. We have none of that stuff going on. Oh, I get disgusted and angry and upset when I talk about this, because I know exactly what this is. Well, let's. Is there anything I'm leaving out here? So back to the APA. Why don't they step up a little bit and start talking about psychiatric care and psychiatric illness and what's on our streets and what can be done about it? I mean, why don't I hear somebody from the APA saying exactly what you're saying, which is the experience of the average psychiatrist in the emergency department?
It's funny you asked that because I'm not an APA member and I have incurred a little bit of wrath from the APA.
Because you're not a member or because you're saying something?
I don't think they actually noticed I wasn't a member, but a couple of years ago I had an article about suicide in the New York Times, and the article was largely about how suicide is like all these other things we're talking about, is very complex, and that antidepressants and psychiatric treatment is not the answer. It's not the only answer. I mean, it is a answer, but it is a small piece of a large puzzle. And there were some folks who I think were really off-put by the idea that psychiatrists weren't uniquely and solely positioned to fix the suicide problem in our country.
That's so funny because it's the exact opposite of the excesses of social engineering and community-based sort of focus that psychiatry had in the 40s, 50s, 60s, and even into the 70s, where the social issues were supposed to solve all psychiatric problems. Are you aware of that history?
Yeah. Yes. Well, that's all we had at the time, right?
Well, no, you had psychoanalysis and you had Thorazine, and you had and you had ECT.
Housing.
But the history of the National Institute of Mental Health is 3 psychoanalysts, social engineers across 30 years, unelected officials, undid the state mental health system that had been developing over 150 years in the name of social engineering, and they had abject failure, top to bottom, and no one and that history goes down as President Reagan ruined the state healthcare systems, and he did close the community mental health centers, and his hands are not clean. But it was these 3 psychiatrists, this guy named Brown and a guy named, and then, by the way, their roads to psychiatry were strange. One was like an entomologist, and one was a pediatric infectious. None of them treated psychotic illness. None of them had seen serious mental illness, and all of them bought the Michel Foucault bullshit that mental illness was caused by institutionalization.
Right.
40 years of psychiatric National Institute of Mental Health policy. Isn't that
Well, and
something?
again, it's back to that whole problem of like, if you don't know what the problem looks like, because it's just been sort of swept
Mhm.
into a corner and
Mhm.
ignored and not looked at for years, then you don't know how to solve it. And that's why it kind of blows my mind how much people are willing to enact all kinds of policies, both in like a health system level and a state and federal level, without consulting mental health experts who actually work with these folks and like know on the ground.
It's like they don't exist. It's like it doesn't exist. So
Right.
so here's another piece for me. I hope you don't mind me bombarding you with this stuff, but I rarely get a chance to talk about it.
No, it's great. I
But-
like to talk about this stuff.
Okay, but there's another piece that we could immediately change to reduce stigma. And I don't know how you feel about this. You may not feel the same as I do, but because I work on the medical and the psychiatric side, I see the glaring differences and stuff. We, humble opinion, must treat the psychiatric medical record precisely the same as the medical record. Making it different is just stigmatizing, and it's persistent in the avoidance of the illnesses, the putting away of the illnesses, and treating the brain differently than other organ systems. And that is anathema. That is stigmatizing.
I've never actually put a lot of thought into this, but I think I agree with you at first blush. Like, you're right. I mean,
so there may be
separate.
there may be aspects of, you know, the personal history or something, or behavior, you know, something about the dynamic stuff going on in a closed door that might want to stay separate. But when it comes to the psychiatric management of the psychiatric illness, that's medical. That's medical and should be treated medically, period, end of story.
And maybe your psychoanalysis notes can go someplace else, like on that, you know, yellow scratch pad you keep in your bottom desk drawer locked up. But I don't think that an EMR in a hospital should have those things separate.
It's exactly
and that
right.
is, you're right, that is a step towards destigmatization and treating this like any other medical disorder, any other medical profession.
Yes, I mean, just like, you know, the notes from an attorney, you might want to have their lock and key, and you might want to have notes in your therapy sessions where you're being encouraged to expose all kinds of things. That is not psychiatry. I mean, psychiatrists can do that stuff, but that's not the psychiatric record so much.
Right.
That's a therapy record or something. So yeah, I'm wild about that. So I'm looking at we have an ongoing chat stream here, and Nathan Barker says JFK signed the Community Mental Health Act of 1963. Yes, he did. It was like his last signature to a policy before he went to Dallas. Isn't that interesting?
Wow.
And the reason he was persuaded to do it was because of Rosemary. And Rosemary was his sister with probably a borderline personality disorder, as near as I can kind of put it all together, who received, because Joe didn't like the behavior, under the consultation with the world's experts, she received a lobotomy.
Yeah.
Rose, the mother, is on record saying that she, in spite of losing 2 sons to assassination, what happened to Rose was still her most painful event. Isn't that something?
Yeah. Well, and
Rosemary,
it gives some perspective to why things in psychiatry are so fraught and why people are suspicious of you know, our input,
listen,
hospitalization.
Let me, I'm going to say something, and I'm going to probably catch some grief for it, and I don't mean to be disparaging towards anybody when I say this, but when I walk past the Museum of Psychiatry on Hollywood Boulevard that the Scientologists put together, I think, man, they got a point. I understand why they can say these things. It's excessive. Please don't listen too much to it, but they have a point. There were excesses. And that's not modern psychiatry. That's not Dr. Barnhorst. That's not.
We've really come back from that. And I will say, you know, there are things that have persisted, like ECT, you know, electroconvulsive therapy or shock therapy. It has a terrible reputation, and it's featured in, you know, every movie that makes psychiatrists look terrible. ECT would be my first choice of treatment for myself or a family member for any disorder for which it was indicated. It works
so
well for people.
I agree with you. I worked at our hospital. We actually had an ECT unit where they were doing about 30 cases a day.
Yeah.
And so I saw inpatient and outpatients getting ECT, and it was life-saving. And I will tell you, my aunt had recalcitrant depression, refused ECT, and died. And that's sort of my experience.
So explain to the layman here.
So here's
what it does.
Let me just put it this way. Everyone now is very excited about what's the magnet therapy called? The
EMS, transcranial magnetic stimulation.
Transcranial magnetic stimulation, which puts a big magnet on your head and then focuses that magnetic energy to create a current in the brain cells, to create the cells to release neurochemicals to raise the neurochemicals responsible for resolving depression. And guess what ECT is? It's doing the same thing while people are paralyzed and asleep. They don't budge even.
Right.
It's creating a current to cause the chemicals to be released. Same thing as the magnet, except the magnet is somehow magical and actually putting a current. Well, we can't do that. It's the same. Magnets cause, those of you who don't know your electrical physics, magnets create currents. Electricity, two poles in an electrical wire creates currents. Same thing, exact same thing. Maybe TMS is a little more focused or a little more diverse in terms of how it can, do its thing. But they're the same thing, right?
They're definitely close. I mean, ECT actually induces a seizure. And I remember when I was a medical student
but don't hang on. But under the influence of curare and you're paralyzed. So, you don't see the seizure.
It's very civilized. And so what they do when I was training and I went to observe it, I remember being so surprised of like, first of all, the patients are coming in here voluntarily and happily saying, I'm so happy that my treatment is this week because I feel myself sliding down again.
Yep.
And they put a blood pressure cuff on the ankle of the person. Yep. And so the only thing that moves is the big toe kind of goes like this.
Sometimes.
And that's how
Not
you
always
know.
Even.
Sometimes, right. Yeah. That's how you can sometimes tell when it's over. And it's very, very peaceful, very effective, really, really low side effects.
And, none of the medication side effects.
Yeah, right.
Now,
that you were treating in the hospital.
Now let's, here we are, both of us, speaking gloriously about this treatment that has a bad rap. Like every medical treatment, there is risk.
Of course.
I would not use it on a very elderly patient. I've seen some cognitive stuff from that.
Yeah.
I've also seen some Parkinsonian stuff or Parkinson's patients getting worse, and I'm not quite sure what that was. So there's downside, but in a young, healthy person, it's usually a course of 6 and goodbye.
Yeah. People do really well with it, and it can happen really fast, which medications don't work that fast.
And by the way, not all that different than the ketamine infusions that people are doing now. The same kind of model, right?
Yeah. And those kinds of emergency treatments that happen quickly can be really life-saving for people.
I'm watching the restream here. You guys got very quiet during that conversation, which is really interesting.
I want to know how we can avoid gun.
All right, let's get to the guns.
Oh, yeah.
Susan wants to
talk guns.
So we're guns are on our mind.
I'm not psychic, but I feel
guns are on our mind a little bit. They can't hear me. That's why they're silent over there on the restream.
They can hear you.
Okay. Oh, that's funny. You're they're quoting the Insane Clown Posse. I don't know if Dr. Barnhorst, I see miracles around me. Effing magnets, how do they work? It's very funny. I think they followed up with Shaggy's kid looks like Shaggy. What's going on? If you don't know the group, it's not as funny.
Not enough to get the reference.
Insane Clown Posse. Just
if you look them up, maybe Susan, you can put a little picture
it in your mind.
Put a little picture of the juggalos up there.
No.
So guns are on our mind because we were in a little shootout in Brooklyn.
Yeah.
And New York is the incidence of violent crime is skyrocketing there, and it feels unsafe increasingly to walk around the streets of New York, seeing the same thing in pretty much every major city. What do we do?
I feel like that kid had mental illness. I'm sorry.
Well,
so there's mass shootings.
Yeah.
And then there's the other firearm violence that's going on.
Yeah.
And
are we seeing an uptick in mass shootings? Is that really true?
Yes, we probably are. Although you can find some articles that will say there's been, 100, 200 mass shootings so far in 2021. The problem is there's no really universally accepted definition of what is a mass shooting.
If 2 people get shot, they call it a mass shooting,
Some people do. Some people require 4. Some people require that 4 killed. And then part of it is that when we talk about mass shootings, we're talking usually about the ones that happen in public, random, the Las Vegas shooting, the Pulse nightclubs, school shootings, mall shootings.
When we used to go to those places.
Right. But the bulk of mass shootings that are 4 or more people killed are incidents of domestic violence, they're armed robberies gone wrong, they're, gang retaliations, or other personal retaliations. And we don't really count those because they're not as terrifying to most of us, because we can think to ourselves like, oh, well, I don't have that kind of ex-boyfriend, or I don't live in that kind of neighborhood, or I don't go to the liquor store that is getting robbed every, couple weeks. But the ones that happen in like malls and churches and movie theaters affect everybody. And to some degree, what you felt at the restaurant, I'm imagining, when this was happening outside, and what we all feel when mass shootings happen, it's like it's bringing this fear to white suburban America that people who have lived in, poorer neighborhoods have had to deal with for a long time, that their neighborhoods don't feel safe, that they worry about getting shot in public places, that lots of people are carrying guns. And, just to grow up like living in that kind of fear, that the rest of us are starting to feel more now as public mass shootings are probably slightly on the rise. But the community violence problem is way more. I mean, public mass shootings are like less than 1% of firearm deaths in the US.
Are guns the problem?
Guns are a huge part of the problem. Yeah. I mean, to be honest, we wouldn't have this problem if we didn't have so many guns. And we have way more guns than other developed nations. And people can get guns really easily. So the kind of, personal beef that happened, it sounds like outside the restaurant where there was the gunfire, this kind of stuff used to be handled with fists, or it is still in other countries. And, the two angry guys square off at whatever the party, the restaurant, wherever the transgression took place. And usually one of them looks the other one down and realizes, I'm going to lose here. And, maybe 50% of the time they walk away. But guns are this great equalizer where they allow anybody to, from a distance, hurt another person or kill another person. And they're common and they're easy to get here. And lots of people have them. And they pull them out when they get mad and in fights.
But that horse is sort of out of the barn. We're not going to get them back in, right? I mean, it's sort of.
We are. No. We're not going to do what Australia or New Zealand did with the big buybacks. I mean, it's too much part of our culture. It's part of how we formed ourselves as a nation. I mean, it was like privately held citizen guns that won us independence from the British. And so it's in our, the Second Amendment to our Constitution. People are not going to let that go. It's very much part of people's psyche and identity.
So then it seems to me a major push should be to reduce the access or behavior or risk of people who are at risk for acting out violently, right?
Yeah.
Particularly delusionally, seems to me. And yet I don't feel as though we're going that way.
Well, it's tricky because the Gun Control Act in 1968 put forth these, criteria by which they prohibited people from owning guns. And they had two around mental illness. So anybody who was, and this is not my choice of language, but adjudicated as a mental defective
okay.
or committed to a mental institution.
This problematic history that we were talking about.
We've come a long way since then, but that's still what's in the law. And what that means is that, you were found incompetent to stand trial or not guilty by reason of insanity, or a judge found that you couldn't manage your affairs, or that you've been committed to a psychiatric institution. Like you've not just been hospitalized, but gone before a judge who certified your commitment. Mm-hmm. So you could be somebody who is in and out of the ER a couple times a month for making threats to somebody else, for, being suicidal. But if you never make it to those checkpoints, you can still buy a gun.
Yeah. That's the part that bothers me. Because it'd be a pretty simple matter. To me, the poster child for the shortfalls in the ability to refer somebody sick into the hospital, the weird endorsement of people with mental illness merely flexing their privileges, and access to firearms, was the kid in Denver. I was reporting widely on this thing. This was in Denver. He walked into a theater and said, I'm the Joker, and started shooting everybody up. It killed a bunch of people in a theater. That kid went before I think it was University of Denver committee that's supposed to be caring for the mental health of the student body. And essentially that committee said, oh, let him, just a kid, he's just being funny, let him do whatever he wants. And I don't have access to these records, but I was looking through what I could get my hands on. And there was a psychiatrist that was taking care of him. And I guarantee you that woman was mortified. I just thought, oh my God, that's the person that knew this was going to happen, probably spoke to the team about it, couldn't get anything to happen, and now has to live with the fact that she couldn't do anything. Do you know anything about that case?
Oh yeah, yeah.
Did that happen? Is that was just sort of my
Yes,
sense?
it did. No, there was a psychiatrist. So first I want to say that he's an example of, it's actually really quite rare that these mass shooters are driven by psychotic delusions.
Yes.
Most of them are driven by a desire for revenge. They're a disgruntled employee. They, want to show their peers how much superior they are to them and open fire on people.
It's personality disorders, right?
It's
sociopathy,
yes,
narcissism writ large.
yes.
Yeah.
Entitlement. It's much more closely associated with that and domestic violence, and also white supremacy groups and racism, and
But I mean, you can look at
anti-religious groups.
look at that through a psychiatric prism too, right? I mean,
right, but they're not people that we're going to get into the mental health system, get them committed to a hospital, and take away their firearms. Or are they people, I'm not going to cure somebody of their white supremacy affiliation,
or their narcissism, or their sociopathy. No,
but the guy in Colorado.
But we could have more tools at our disposal to manage them, for sure. So the guy in Colorado is one of the rare ones who probably really did do that because of a psychiatric disorder that he was clearly
delusional.
Schizophrenic. He was clearly.
And his psychiatrist considered sending him to a hospital, but she went through the calculus that, all of us have gone through so many times, which is like, he's just going to get discharged. He's not going to meet criteria to be committed by the judge. And there's nothing else I can do at this point. And this is where, people don't quite understand that by putting him on the emergency psychiatric hold or doing the 72-hour evaluation that most states have, you're not like solving the problem. You're getting them into the doorway, but there's a lot of other checkpoints they have to go through before either one, they take medication and get better if they actually have a treatable condition, and two, before they're prohibited from buying a gun.
Mm-hmm.
So this is why I actually got involved with a group that helped pass a lot of the red flag laws across the country. It was when they were drafting the legislation in California. And I got involved from the perspective of a psychiatrist like that woman in Denver, who sees these folks and says, psychiatric hospitalization or commitment, or even psychiatric medication and treatment is not going to be curative here. But boy, do I not want this guy to have a gun.
Well, two things you mentioned that we didn't, I want to dig into a little further. You mentioned long-acting antipsychotics. Why aren't those used more?
Well, they're not used more, I think, largely because we have to have consent for them from patients or a judge's order. And patients do have, you mentioned the side effects. I mean, antipsychotics are really helpful, but they're no joke. They come with a lot of the whole array of side effects. And
risperidone is pretty good. You know what I mean?
It's pretty good. I mean, it's all a balance, right? Like how bad are their symptoms of psychosis versus how bad is it going to be to gain 10 pounds, maybe, have some other side effects from it. So we can't force them on people if they have the capacity to say no. And if they're able to explain to a judge, like, listen, I'm really afraid of needles. I promise I'll take my pills. I think I'm getting better. We can't just say like, I think this is best for you and I'm going to do it.
Right. I agree. But my suspicion is it may have more to do with cost. That's what I was starting to think. Cause it was not even being offered to a lot of people. I thought that was problematic.
Well, some of the new ones are really pricey, but there's old ones that work really, really well, and they are dirt cheap. So I actually use a lot of them.
Which ones are dirt cheap now? Haldol, obviously.
Yeah, and Prolixin also comes in a long-acting shot.
And those two have lots of side effects. I'm not going to kid you. Those two do.
No, they absolutely do. So it's always weighing those risks and benefits for people, but I mean, I think they're great. I really do. I really like them, and I use them when I can, and I try to talk to my patients about them when I can.
Why don't we have more universal application of something like a directive to physicians, directive to psychiatrists? It seems to me that certainly every psychiatric patient ought to have one. Let me define for people what I'm talking about. And I think every citizen ought to have one, which is people like me, you give me a directive what to do if I'm unconscious, if I'm on a ventilator, if my brain isn't working right, what decisions I want you to make on my behalf. That's pretty much guaranteed to happen with serious mental illness. Why don't we at the time of diagnosis go, we need to discuss what we're going to do if you decompensate again. See how good you're feeling now? We could, if you get decompensate, you're not going to want to see me. You're going to refuse everything. Let's make out a plan for what we're going to do, and let's codify it. Let's put it on a legal document. Why aren't we
Yeah,
doing that?
there was a movement about this. A couple of years back, one of my colleagues at Duke was working on this,
Yep.
and they were coming up with a plan for it. And I think it's a really good idea, especially for people who, for example, have a very episodic illness like bipolar disorder.
Yeah.
Where they do great until they have a serious episode.
But even schizophrenia, when they're stabilized,
right.
they're very, they can be very productive and reasonable, and
right. And they could say, like, I consent to a long-acting injectable medication.
Exactly.
I want ECT. That's what mine would say is if it's indicated for this, I would choose certain medications. I would choose certain treatment modalities.
Yep. And by the way, it's something we can revisit and modify, just the way I do with elderly patients. I do it all the time.
Right.
And psychiatry just doesn't do it. And I feel like if they did, a lot of the stuff could be managed differently, which is the other issue, which is I have not seen somebody since only successful. I've seen two people successfully get a conservatorship with chronic mental illness, and one of them was Britney Spears. So you know what I mean? It's so rare. It's so rare that I don't ever see anybody get conservatorships, and I've seen them be life-saving, and I know they can be life-saving, and I've had patients die because families refuse to do it.
Yeah.
Should we have more emphasis and easier access to conservatorships?
I mean, we use conservatorships a lot where I work. There's a team of about 20 patients that I covered a few weeks ago, and I would say the majority of them were on some kind of conservatorship. But again, they're sort of the long-term chronic
severely.
Yeah, they're very ill,
yeah.
and it's a lot of it has to do with funding. Part of it, and again, this may be the population I see, but they don't have a mom or a brother or somebody in their lives who can reasonably care for them and make all their decisions and do all the court paperwork and navigate that process. That's part of that social and community support that is contributing to the worsening of their illness. So they get a public guardian, and I think the public guardians, like all public institutions, they're overwhelmed, they're underfunded, they're understaffed. So it's hard to get the kind of care. They do a really good job with the patients they take care of, but it's partially not having enough resources at that level. And then also, again, that balance between keeping people's civil liberties. Like, a lot of people don't want to be on a conservatorship because they don't get to manage their own money, make their own decisions. They don't want those things taken away. And there is a tipping point, before which you could say this person deserves the right to make those decisions on their own and to do things for themselves. And who's the person who gets to decide when you cross that line? I think that's the really tricky question.
Well, clearly we haven't. People are dying because we're not making that line better. We're not working to find that line more in a more therapeutic manner.
Well, and I think 100 years ago in psychiatry, the line was way over here. Like, whatever the doctor said, you just did it. You got no say. Sorry, no judicial process. And now we've maybe push the line a little bit too far this direction. Maybe we could scooch it back a little.
Correct. And let me shine a little light on something Dr. Barnhorst just said. That was 100 years ago. 100 years ago. Literally 100 years ago. And so we are continuing to push back against policies from 100 years ago. It'd literally be the same as saying, I don't want to go into surgery because the surgical outcomes are so bad. They're terrible. People die after surgery. The exact same thinking from 100 years ago. So it's too much for me when people, bring up
Is
Michelle
your mic flying away?
No, nobody could hear me.
Oh, why?
You wouldn't. I kept saying they're not hearing me, so I have to put the mic up to my
They
mouth.
can hear you.
Now they can. Yes, they can.
You want to say that again?
Why would happen? Okay. is that I don't want to hear complaints about the behavior of psychiatrists 100 years ago, maybe 150 years ago. We're talking about in reality.
Right.
We must get over that. My God. And think about this. The thing, the Ken Kesey product got people exercise over this was 60 years ago.
Oh.
There's the 1960s when One Flew Over the Cuckoo's Nest was published. 60 years ago. Let's get over it. We have moved on to a modern science. Oh my God.
Yeah.
So again, where's the APA? Where are those guys?
Well, and I think it's all people have now when they think about psychiatry are the 100 years ago history, One Flew Over the Cuckoo's Nest, And the people they see with some kind of mental health problem that are still in their lives, they don't see these folks with serious mental illness who are unable to manage for themselves, who are going off their meds, who are putting themselves in danger. And it's hard to understand what those solutions are.
Well, they see them in the streets, even though everybody in the government goes, oh, that's because there's a healthcare, there's a income disparity and housing is expensive.
Right.
No, that's not why they're in the streets. That's not why. And why we can let that lie persist is literally killing people.
Yeah.
I don't know. Well, listen, I love talking to you. This has been great. Did I miss anything? Is there anything more that we should be discussing as long as we're solving the world's mental health?
Lots. Yeah. Boy, where to start?
I think all the mental health people ended up on YouTube today. I've been knocking off trolls left and right.
What are their issues? What are they?
Oh, they're just being silly.
I can't see them. That's interesting.
I know they're not. I think the restream blocked them, but it's fine. It's just funny. I said, "Where's Tom?"
Tom Cigars.
Yeah.
He was in there. I saw him. That's why I knew there was something going on. He was sort of responding to stuff.
Well, and that's part of being a psychiatrist too, is that people have a lot of really negative transference towards you because
hate doctors.
Sometimes we do things that are not what people want in their state of crisis. And sometimes they, remember what happened 100 years ago and attribute that to us. And I come to peace with the fact that I'm never going to be one of those doctors that, like, my patients' families bring me pies over Christmas and send me Christmas cards. I don't get thank you notes, really.
And there's another piece of this too that that's really funny.
Terrible.
It's very funny.
I have gotten some
thank
thank you
you
notes.
They came to not like it, and they hate doctors. So you're right.
Yeah,
the last
absolutely.
one, I didn't block that person yet. They have a right.
Well, here's the thing about us in mental health physicians: we are a piece of a team more often than not.
Yes.
And that with mental illness, you must surround the patient with a cohesive, well-trained team where everybody knows everybody in terms of their skill set and how they approach patients, because it's easy to give people money and send them back out on the street. That is easy. Struggling to fight their mental illness is a war, and you cannot do it alone. So it's not just Dr. Barnhorst pulling out her prescription pad. There are psych techs, there are mental health workers, there are maybe chemical dependency counselors, psychologists, social workers, and Dr. Barnhorst will know those people. So when the patient comes in and says, Dr. Barnhorst, the social worker's a bitch. She told me I have to go. It's like, no, I know that social worker. She would never say that. She would never say that. And by the same token, when they go to the social worker and say, Dr. Barnhorst's a bitch, she won't give me any benzodiazepines. The social worker can go, and let's get to work.
And that team is so crucial. I mean, everyone on it, from the mental health workers to the nurses to the social workers,
I left out nurses, and that's shame on me. Shame on me. The nurses are extremely important.
Yeah,
extremely important.
Okay,
they know our patients
Dr.
really well.
Drew,
yeah,
you need to give a birthday shout out.
Okay, to whom?
Nick Gertz.
All right,
sing
Nick.
Happy birthday.
No, I'm not going to sing happy birthday, but I will give Nick Gertz a shout out. Happy birthday, Nick.
Okay.
Why?
Happy birthday, Nick.
Why is he one of the?
It's his birthday.
He's not one of the trolls
No.
you're trying to subdue.
No, I thought I'd.
So,
yeah.
oh, there it is. Please, the flat Ronnie is asking us to give him a shout out.
Nick, I wrote down his name. I was going to say it at the end, but I thought I'd.
Okay.
Just.
Well, we're just at about at the end.
Sorry, there are happy people on our stream. Usually.
Yeah.
Usually we get
these are topics.
I think we had this weird magnet that just drew
because the alternative is Dr. Barnhorst and myself can leave people out on the streets and in and out of the emergency department and die. Yeah. And just die. That's what we can do. That's our alternative. We can fight this thing and try to make people better, or we just leave them on the streets to die, because that's what will happen. These are serious illnesses, and they end in death.
Well, I just worry about the common citizen getting shot by these people in the future. I think like.
Well, what do you mean by these people? You're getting weird when you say that.
I think we have a lot more mental health issues now because of COVID-19 and lockdowns. And
but let me refine. Dr. Barnhorst pointed out that there's mental illness, then there's people on the cusp, and then there's all of us kind of struggling. Those are not. I think that's right. It's that, I mean, it's not like we're going to see a lot more serious mental illness because of COVID.
Well, the people, I think the uptick in firearm violence and violence in general is definitely is not attributable to people with serious mental illness. It's not like we have many more delusional people like the guy who shot up the movie theater. What we have are a lot more guns and a lot more people who are frustrated and angry, but those are not people with mental illness. That's not who's out there.
I mean, to be fair,
shooting in front of the
they
restaurant.
may have an Axis 1, whatever. They might be depressed. They might be whatever.
Anxiety disorder, but that's not what's causing the problem.
Right.
There's a difference.
That's exacerbating, or it's not as though that makes the difference. Like the kid that thought he was the Joker, the mental illness caused that, and that's it.
The rest of it is angry young, mostly men with guns,
which now is back to the social stuff we were talking about earlier.
Yes, exactly. And this is where investing up front.
By what's going on, and they're fighting back.
Well, yes, you could argue that part of the social problem is people feel helpless or marginalized by their government or their community, and that is not a good thing. It's a disaster.
Or they have drug problems.
They're scared.
And you put meth in, and then it's all bets are off.
That's the end of it.
It's not really a mental illness. That's just a negative emotion that becomes overwhelming and people act out on.
Right.
Very different than
the meth, though, is a mental illness.
Once
with the meth in,
substance use illness, yes.
Yeah. And just for people's benefit, the psychosis associated with methamphetamine is particularly destructive. It's elaborate. I've seen some of the most extraordinary delusions I've ever seen, and it's always focused on family, friends, coworkers, neighbors. I don't know if you've noticed that, Dr. Barnhorst. It's always people close, and relationships.
A lot of paranoia.
And the paranoia is profound. I've seen people just do crazy stuff, and then it can become a little more. They'll turn off everybody in their life. And then it could become a little more generalized, where the planes or the satellites and the foil in the head and all that stuff, or the mafia or the FBI or the CIA, whatever.
The foil in the head.
Well, I've literally seen people put foil in their. I've seen people put foil in their windows all the time. Yeah. But that's actually a little more cocaine-ish. The cocaine psychosis, for some reason, goes to the windows, the curtains, and the foil. And it doesn't resolve when they stop doing the meth for a long time.
Right.
Which is
sometimes never.
Crazy.
And the meth does have potential to damage the brain. It just does. It's one of those drugs.
Yeah.
And you add meth and opiates together, you have an extremely dangerous combination of a fatal illness, opioid use disorder, and something that will induce delusions and make that person unmanageable. Terrible. Just beyond.
And they all live in California.
And I'm telling you, these are manageable conditions if we had the tools, if we had the laws in place and the beds available and the resources. But as it is,
Dr. Amy, how is your community as far as the homeless situation?
This is up in Davis. She's up in Davis.
I'm actually in Sacramento. So the UC Davis Medical Center is in Sacramento, and I live in Sacramento. We have a really large homeless population. We have a ton of methamphetamine.
Yes. So I've been up there, and I've been in the streets with your people. And it's a very unique and unusual cross section of homeless, right? Think about, you tell me if I don't have this right. A lot of alcoholics, a lot of bad alcoholics. I saw that. Really sad alcoholics, like they should not be that far gone. Like come on, everybody. Number one. But the rest of the people that I encountered and dealt with, interacted with on the streets, and the cops who confirmed what I was seeing, these are little meth gangs. They're mixed sexual. They're men and women in these little gangs that have pit bulls. You notice that, the pit bulls?
Oh yeah, lots of dogs.
They all have pit bulls. You don't see any dogs down here. We don't have that. They all have pit bulls.
Really?
Well, I mean, sometimes they'll use dogs as sort of a way to get resources, but you don't have the pit bull thing at all, really. And they are all these little meth gangs that wander around the city. It was unique to Sacramento.
This is in Sacramento,
Yeah, unique. To, I was
did a tour.
Yeah, I spent a day up there running around examining stuff, and I was really surprised how much of that there was. It was very unique. Because down here, the meth is
spot on. I mean, I don't worry about homeless people when I'm riding my bike by the river going for a run, but I really worry about the dogs. We've got a number of bites and attacks.
Unbelievable number of pit bulls. It was really extraordinary to watch. Down here, the meth is, I would say, more commonly with opiates. It's not pure meth. That's all pure meth.
I mean,
That's
having
straight
a
up
pit
meth.
bull's kind of cool. Like if you want
It's
to make
cool.
sure nobody's sneaking up on you. You know?
No.
I mean, I
So
see
they're
why
like,
people do it. It's a good point. You know, people want protection out there, and that's why a lot of my patients start using meth. They want to stay up all night.
Yeah, but here's why I love pit bulls, because they know all the other meth gangs are paranoid and agitated and violent, and they need to protect themselves against the other meth addicts.
Didn't we talk about that earlier when the dog was whining and I said we don't have guns, we just have guard dogs?
Yes, you did say that before the mic's heated up. But it's man, I mean, it was really extraordinary up there, really crazy, and then nothing from the government to help structure this or deal with it or manage it. I went into some of your SROs too. Again, no treatment, no nothing, a lot of drug use, a lot of alcohol. It's just why are we bothering?
That's the capital of California.
I know.
We just don't have a concerted plan for the resources. I don't know.
Denial. It's absolute denial that that's what's happening. You hadn't even sort of conceptualized it that way. I'm telling you, I went up and looked at it. I know what that is. And it took me a day to figure it out. And talking to the mayor, oh my God, you would have thought I was saying that the whole, that a Martian had landed in the town square. You know what I mean? There's just no awareness of what's going on.
Yeah.
And by the way, I got up and I was excoriating in the lecture I gave, because I think it's homicide, or at least manslaughter. I really do. I think this is manslaughter.
They live such horrible endings too.
It is really hard to see people living that way and knowing that there's not shelter beds, there's not treatment programs, there's not inpatient psych beds. It's just, we really need so many resources at every level. There's not one thing that even tops the list. It's just so much.
Okay, so hold on. Somebody's getting on the restream here. Don't forget what happened to the psychiatric hospitals. Yes, Shaw, we talked about it for half an hour. It happened 100 years ago. 100 years ago, or at minimum 60 years ago. Horrible things happened. We agree. We have moved past into a modern era. Minimum of 60 years ago, since Ken Kesey wrote One Flew Over the Cuckoo's Nest, 100 years ago, they were engaged in those excesses. Nothing like that goes on anymore. Thank God. I lived it. I saw the horrors. It was terrible. I agree with you. That's why we don't do that anymore. But allowing people to die in the streets is not the answer. Sorry.
And we so often have families that are saying to the judge, please keep my son, keep my brother, keep my husband here. Like
all the time.
He's so sick. You've got to keep him. And someone's saying we don't have the criteria met. We can't do it.
Yep.
This is what I have gotten are from families.
I have taken families up to Sacramento begging legislators to please expand gravely disabled. Wouldn't that make a huge difference? Yeah. Expand gravely disabled. Please give us greater powers of conservatorship. Scram, who are you? Who do you think you are? And the kids end up dead. Really well done,
a lot
legislators.
Of states don't even have gravely disabled. We're considered,
our gravely disabled is pretty weak. We don't have much. Listen, we used to have gravely disabled for real. I mean, it was a pretty usable thing. And now doctors are afraid to use it, frankly. Yeah. So I don't know. So, all right, I'm done. I'm mad. I'm upset.
Not to get you riled up.
Good luck with your work. It's like you gotta enjoy going back out into the streets.
She's gonna go, wait, why did I do this interview?
Thanks for the conversation. It's an important one to have, and it's not talked about enough. And I really wish people would get a better view of what the problem is and how sick folks are who have serious mental illness and how complicated the solutions are and where we need our resources.
But how well they can do when they're properly treated. This is the other part they don't see. I mean,
really
you and I both know we both
Where's Anthony
successfully
Brown?
treated lots. Yeah, that's why I love talking to Anthony Brown. We're going to get Eric Smith back in here. He was a severely, psychotic bipolar who got assisted outpatient treatment, and now he's a patient advocate. He's a therapist. It's just perfect. He would have been dead on the street smoking meth if in California. That's it. And so it's a lot. It means a lot for me that, and you please do push back. Am I saying anything with excessive force or hysteria, or am I overstating anything?
Is this Dr. Amy Strikes Back?
Yeah, Amy.
Is it my turn to strike back? I don't have I can't think of anything you said that seems way off base to me. But
even marginally off base.
Marginally off base. Well, I'll have to go back and rewatch the episode. I'll email you.
All right, good. Because I get so upset about it. I worry that I'm getting rhetorically, compromised. But
No,
but
it's a
You scare
frustrating
people.
system, and people don't know a lot about it, and that's part of what's frustrating. Is they don't even just know, they don't even know what you're talking about when you talk about needing more inpatient beds and needing a little more looseness in how we can get people into treatment.
But that our government fights us on this is again anathema. Just so disturbing to me. So disturbing.
They don't see what we see.
But they should be talking to you and asking what you see. That's what they should be doing. Yeah,
I agree.
You're laughing about that, like, ask the doctor what's going on.
But that's, they should. I mean, nobody would set up a dialysis clinic without getting a nephrologist involved. Nobody would set up a surgery suite without having the surgeons weigh in.
As I said, 5 a day are dying on the streets just of Los Angeles.
Yeah.
And that goes down as, oh, well, if they just had a home.
Right.
No, that's not what that is. That's not
More
what
than that.
Well, listen, thank you so much again at Amy Barnhorst, Barnhorst, where you can follow Dr. Barnhorst. And the Bullet Points Project. Tell us about that.
Yeah, the
quickly.
Bullet Points Project is at BulletPoints Proj on Twitter, or you can check out our website. It's a kind of a one-stop resource for healthcare providers who are interested in counseling patients about keeping themselves and their families safe if they're gun owners, if they have firearms in the home. How can they reduce risk of firearm suicide or violence?
That's great. Well, thank you so much, and keep doing the good work. We need more of you out there, as you know. I hope. Are you teaching residents at all?
Yeah, I teach residents. I teach the second year medical student course on psychiatry in the summer.
And are you seeing more people come your way in terms of?
We have a pretty good crew that comes from Davis that joins psychiatry as a specialty. So we do a good job of recruiting students. I don't know if that's increasing nationwide. I hope it is. I know they're really trying to incentivize people because we really need a bigger workforce.
Well, California to me seems at the bottom of the pile in terms of needing psychiatrists. So.
Yeah, we really do. Not like New York where there's one for every 60 people.
I know. Well, they've got, New York's kind of an interesting place, but they have their own problems. But they generally do a better job with things, even though they have big problems there too.
Yeah.
All right. Well, thank you so much. And if anything I do to help you in the future, please let us know. Okay.
Great. Same. And it's fun to talk about this stuff. So thank you both.
All right. Thank you. And
Okay.
Dr. Barnhorst, thank you. And those of you that have been on the restream, well, we appreciate you guys hanging out. I don't know who the trolls were. I didn't really get to see any of that, thankfully. It would have only upset me. Susan, anything else before I wrap up?
Yeah, they were pretty. There was one guy. I saw you guys on YouTube. I didn't catch it fast enough. He got reported, but he wasn't just in a timeout. But I'm sorry. And also, I'm not gonna always block you, but because I'm trying to be open to your comments, because everybody has a right for that. But when you just repeat the same thing over and over, and it's degrading to women, you're out. Sorry.
No
over. Done.
Walkthetalkamerica.org. Okay, I'll click on that. Thank you for that. Walkthetalkamerica.org. Oh, this is about bridging the gap between mental health and safe firearm ownership. Okay, very good. Excellent. Thank you for that. And tomorrow we're going to be doing something.
Everybody wants to be a troll on Twitch. That's the funny part.
Tomorrow we're doing something around 4 o'clock. Is that okay, Susan?
Yeah, whatever you want to do. I'm pretty easy.
Okay, we might do a little clubhousey something.
I have a lot of stuff going on. I might have Mary Carey on
Oh.
because she's running for governor.
Oh, it'd be great to see how Mary's
And I
doing.
was going to try to get Seth Binzer too, but I don't know. I'm working on some stuff, and I was also working. I was going to try to get Angela Deem from 90 Day Fiancé.
That would be great. See how she's
because
doing.
she had her
Surgery.
Yeah, and I want to hear about her weight loss surgery.
All right, call
And
her.
she gave me the wrong email, and then I got super busy.
Gary has contact for her.
No, I have to okay it with her. She gave me the wrong email for something. I got really busy today.
You have been busy. This has been a rough few weeks.
Yeah,
It really has.
But we'll be here. We'll come back. You guys can troll us again anytime. But I
Art Cigars, Tom Cigars, I am you. That's what I was worried about, Tom Cigars.
He's found a
Art
lover.
Cigars was you.
He's found a lover on Twitter.
Tom Cigar says he's the Dexter
Twitch.
of trolls. We love that.
I just didn't see. I saw it. I was like, uh-oh. And then I went to YouTube.
What did he say?
I'm not repeating it. Oh, God, it wasn't.
It was
good.
misogynistic? Is that the
Terrible.
Oh.
Terrible and very officious and sexual and stuff.
Okay, not okay. Okay, well, we'll be back tomorrow about 4 o'clock. We might even do something on Saturday.
And
Mrs.
Sunday.
Pinsky is telling me.
Yeah, I got a few people. It just... Yeah.
Wait. And Sunday.
Yeah.
Because I'm going to be gone all next week.
I'm
I've got to go to New York and do a
pulling
teen
some
mom
people
thing.
out of my butthole this week.
Out of your butthole. That's nice. Thank you for that. And what did this guy say that was so terrible? This offended your sensibilities? Okay.
It was pretty bad.
Okay.
Well, everybody needs to know what I'm dealing with these days. It's pretty crazy. My house is torn up. And
yeah, it's getting a little tiresome, isn't it?
I'm trying to get my family's all coming together. I was booking hair appointments for Paulina behind the scenes, and everybody's coming to me at the same time. So.
All right. Tomorrow around 4 o'clock. We'll see you guys then. Take care.
Okay. And don't forget your hydrolyte.
Anyone who's watched me over the years knows that I'm obsessed with Hydrolyte. In my opinion, the best oral rehydration product on the market. I literally use it every day. My family uses it. When I had COVID, I'm telling you, Hydrolyte contributed to my recovery, kept me hydrated. Now, with things finally reopening back around the country, the potential exposure to the common cold is always around. And like always, Hydrolyte has got your back. Hydrolyte Plus Immunity, my new favorite, starts with their fast-absorbing electrolytes and adds a host of great ingredients. Plus, each single serving easy pour drink mix contains 1,000 milligrams of vitamin C, 300 milligrams of elderberry extract. Hydrolyte Plus Immunity comes in convenient, easy to pour sticks that rapidly dissolve in water, make a great tasting drink, has 75% less sugar than your typical sports drink. Uses all natural flavors, gluten-free, dairy-free, caffeine-free, non-GMO, and even vegan. Hydrolyte Plus Immunity is also now available in ready-to-drink bottles at the Walmart next to the pharmacy, or as always, you can find it by visiting hydrolyte.com/Dr. Drew. Again, that is HYDRALYTE.com/DRDREW. Be sure to use the code Dr. Drew 25 for a special discount. I've struggled with various digestive issues over the years, so gut health is extremely important to me. Now, while gut health awareness has increased, it has led to a wellness trend that inspired a host of kind of questionable marketing claims and even false claims. You've seen the word probiotic attached to all kinds of supplements, drinks, and more, and they may claim to deliver the healthy microorganisms our guts need for proper function, but all too often the promises are really too good to be true. Thankfully, I became aware of a company called Seed and their flagship product, the Daily Synbiotic. That's right. Seed's Daily Synbiotic offers 24 clinically researched strains of microorganisms in a single dose. These strains support gut, skin, and heart health and promotes regularity, sometimes within as little as 24 to 48 hours. To me, what really sets Seed's Daily Synbiotic apart is its delivery system. This is my supply. While some products may offer the right strains, they are fragile and they rarely survive the trip through your gut. Seed uses a capsule-in-capsule design that helps ensure that 100% of the probiotics reach your colon where they matter most. Now, I've been taking Seed's Daily Synbiotic, and I encourage you to check out their story and the science behind what they do. To try it for yourself, just go to seed.com/Dr. Drew. Use code Dr. Drew for 20% off your first month of Daily Synbiotic. That is seed.com/Dr. Drew. Use code DRDREW Dr. Drew.